There's still an awful lot of research that needs to be done on this to decide what's best.
What is the success rate of this PRP in general?
Some people are getting very, very good outcomes from it. Either really good or they don't work at all. There seems to be a tendency for people to get knee replacements at an earlier age. The results are always not as good as you would hope. Opiates have no place in the treatment of osteoarthritis. They just create people who are addicted to opiates.
Thank you, Dr. Peter Shah. Thank you for joining me on another podcast. And we're going to talk about other treatment options available for arthritis of the joints.
Okay.
So, if you haven't watched my previous episodes about arthritis being a disease, systemic disease, and how hyaluronic acid can help you, please watch those 2 episodes before you take a look at this third one. This is going to be another interesting conversation we are going to have. Mainly, we are talking about the other treatment options available for this systemic disease we are handling. We are going to talk about PRP injections, steroid injections, and we can talk about adipose tissue injections, stem cell therapy, arthrosmede, and there is the major thing about surgery itself. So, whatever we are talking here is not that everybody should explore everything. Again, you should get your independent medical opinion from your own doctor or a highly qualified physiotherapist or any healthcare professional for that matter. But again, we are exploring all the options available for the treatment as a treatment for the arthritic joint. So don't get confused, even though we talk quite a lot about it. I don't know if I'm confusing them or not, but there are a lot to talk.
There are, and there have been a lot of recent advances in the last really 5 years in this area, and maybe accelerated by the COVID pandemic and the fact that people were unable to get surgery and other options were looked at. There's still an awful lot of research that needs to be done on this to decide what's best and what combinations are good and what isn't good. There's increasing use of PRP in the United States now. And then it's what PRP is better than another because they're all slightly different. And of course, one person's PRP is going to be different from the next person because you get it from the individual patients and then re-inject it. I just came from a conference in the United States actually last week, which there were a number of very interesting presentations on it, and the conclusions of some of the presenters were. Especially in osteoarthritis, is that the platelet count is really important, and getting over 10 billion platelets is a good
donor site kind of
amount in the 4 mils or however much you're going to be re-injecting into your patients. Lack of red blood cells is another thing that seems to be good. So, and then leukocyte poor or leukocyte rich, depending on where you are. So the PRP is changing, and then there are a number of interesting studies looking at the combination of PRP with hyaluronic acid.
Oh, they have done that too.
Yeah, so combination PRP plus high molecular weight HA. And there are a number of studies that show that the combination is better than either alone. So you get a better response to PRP plus HA than you do to either PRP or HA alone. And then the argument is, well, when do you give them? Do you give them sequentially at the same time, or do you separate them out by a few days or a week? And this is somewhere where I think people are still doing research, but more and more of the papers that I've been looking at and people I've been speaking to say you do it at the same time. So you do get your
PRP first,
inject that, and then change the syringe and put HA in at the same time. You don't need to bring them back a week later and do it then.
So less trauma to the joint.
Yeah, and also, unlike steroids, there isn't a deleterious effect of putting them together like there is with steroid and HA. So you can safely do the two at the same time.
So if you're thinking, what does PRP means? It's nothing else. It's a high-rich platelet count. We take it out from our own blood and spin it and take the high-rich platelets, put it back into the area of the problem. You could inject into the tennis elbow, osteoarthritic knee joint, shoulder joint, anywhere. Because the platelet has got a high amount of healing factors, and that enable the healing faster and better. What is the success rate of this PRP in general for multiple other joints? Because we have done it for the elbows and knee joints.
I think it depends who you're talking to be honest with you. Its use is increasing in osteoarthritis, and some people are getting very, very good outcomes from it. A number of papers have sort of said, well, the outcomes are really either really good or they don't work at all, so there's a wide variability in it. But that was 2 or 3 years ago, and I think it's getting to the point where people are starting to work out what's the best combination in any individual. Talking to clinicians who do it,
yes,
particularly the sort of orthopedic sports medicine group, is they find better success in those people with the more soft tissue injuries,
yes,
the ones that you were talking about earlier. And that I will leave them to talk about, because I do not have the relevant expertise. That is really third-hand information that I'm getting from what I read and people that I speak to. But they seem to get better results in those younger people with the more soft tissue and acute injuries rather than the more chronic and long-term ones. That's really where maybe the combination is going to be.
It's going to be effective.
Yeah.
I've seen lots of clients with the tennis elbow who had the PRP injections, Achilles tendon, they have done it, and also the wrist RSI injuries, they have done it there, and it seems to work very well. But I have seen quite a few patients who had it in the knee joint, and the results are quite varying. And they couldn't put their foot and say that, yes, it worked. And they couldn't say, I don't know, it hasn't worked. And it's quite a mixed review about the
And I think the literature would back you up on that. You can read as many papers that say it's great as say it didn't work in certain people. But ultimately, in most environments, it's something that doesn't get reimbursed. So the cost comes into it.
Yes.
Especially in environments where it's only done privately. And under the veterans system in the US, there are a number of veterans hospitals which actually offer PRP to their patients at no cost. But they're paid in a different way.
Yes, yes.
And they're having success with it. And those that don't respond as well as you would expect to PRP, then a combination of PRP
and high
molecular weight HA is probably the way to go in those people as the next step of a possible treatment for them.
Let's talk about stem cell therapy.
Okay.
So what is your experience about this stem cell therapy? What do they do and how does it work? As a medical doctor.
It's very much in the same way as by putting stem cells in, you're putting those progenitor cells in that will stimulate healing in the tissues. My own knowledge of it, I would say, is fairly limited. The mechanism of action is similar to others, is you're putting in growth factors and these primitive cells, which then are able to initiate a healing process. There are a number that are available. There's bone marrow concentrate that's used, and then there's adipose tissues and mesenchymal stem cells that are used. And everybody has their favorite. Some can be done as an outpatient procedure. I've heard of some people doing bone marrow aspirate as an outpatient procedure. I'm not sure that I would want that doing as an outpatient procedure, but
so what do? They take out the bone marrow?
They put a needle into the bone, aspirate it, and then put it into whichever tissue they're putting it into, yeah. Sounds like it's a little bit more painful.
Yes.
One of the things you always taught, there's no gain without pain, but there's only a certain amount of pain before
you can tolerate it.
Exactly. And I think in most of these, the pain is financial, isn't it? The cost of these things is going up, and I certainly in the United States, PRP will never be covered by
Okay.
Choose your own.
Yes.
The cost
Because
of
it's
doing,
not a medicine.
The cost of doing it may be because of the equipment required and the operation time and the time in the clinic and things, but the rest of it comes down to the individual provider doing it, I think.
And the same way, there is another procedure which is around in UK, and I have seen a few clients getting it done in London. It's all about taking your adipose tissue and separating it, then putting it back into the normal healthy joints.
Yeah.
And they prevent arthritis settling in or even starting in the early
I believe
stages.
it's the same theory, is there's a concentration of growth factors there and within that tissue. And it
High,
works.
level of proteins and everything inside the joint binding the cartilage so that the wear on the cartilage will not happen or doesn't even start at all. And I hear that it's quite expensive here, but these are the treatments available.
Yeah, and as you said right at the beginning, it comes down to the individual provider that you're seeing is where their expertise.
Yes.
I think the most important is to go to somebody who does it very frequently and knows a lot about it. And
Yes.
those ways of finding.
But
those.
again, all these procedures have a limited research, backing. Some of them have very less, backing to say that it works absolutely fine. They wouldn't even give you. These are the patient group or cohort of the patient need to be done. So it's worthwhile talking to a very skilled person in that field altogether, I believe.
And that is not me. but I would say it comes down to the individual and the theoretical likelihood of these products working is all very sound. There are tissues where these growth factors are plentiful, and the way of concentrating them down and injecting them in and knowing that they're going to a diseased joint or a diseased tissue or a soft tissue where they're going to have benefit. And the fact that there are so many where it works means there's a lot behind the theoretical work, and I think we're all aware that this is the next advances in these chronic diseases is how can we do it. There's an awful lot of research going on with tissues taken from the amnion, the chorion, and the umbilical cord. So because that has a lot of those growth factors in it, that come from healthy, normal babies.
Yes.
Where you retain the placenta and the umbilical cord and the chorion, the amnion, and the umbilical cord, and you can make that into products that can then be used for tissue regeneration and for osteoarthritis.
Wow. Okay. So much more happening, and people are doing so many other products available there as well. And the next step, we want to talk about total knee replacement together. Is there still, I'm sure, patients will always need a surgery, and there are, these procedures will have their own place in the journey of the patient. What you are thinking at the moment, how many patients, do you think the number of patients who will need a knee replacement will going to go up, or is going to remain the same, or is going to go down in the advancement of the procedures we are talking about?
That's a great question, and I think there's a short answer, and we don't really know. The more longer answer is we do have an aging population.
Yes.
In certain countries, we have a population that's getting larger, and obesity leads into this condition, as we talked about in the first podcast. I think for the foreseeable future, there is always going to be a need for joint replacement. I think as clinicians, we need to try and delay that as long as possible, because the results are always not as good as you would hope they would be. I think that's probably the kindest way of putting it. A lot of people do really well, but there's a number of people who have more problems post knee replacement than had before. Knee replacements, as a rule, do not last as long as hip replacements. So what you want to do is trying to delay that first knee replacement as long as you possibly can, so that maybe that patient will only require one in their lifetime. Unfortunately, the data that from certainly the United States, and I think it's being replicated elsewhere in the world, is that there seems to be a tendency for people to get knee replacements at an earlier age and at a younger age and at an earlier stage of the disease. There's now nearly 1.3 million knee replacements done a year in the United States,
Wow.
which is, for a population of 350 million, that's a lot of people.
Quite a lot of people.
A lot of people getting them done every year. And there's a number of researchers that suggest that over half of those will require at least one revision in their lifetime, especially those that are getting them done at a younger age. So trying to do it later, as clinicians and physiotherapists and, you know, those people who are really at the coalface of this disease, is trying to delay that for as long as possible. And then we always have to remember that there are some people who just physically aren't suitable or fit enough to have knee replacements done.
Absolutely.
And then the treatment in those, you need to have multiple things to be able to offer them in order to at least give them symptomatic relief things. It may be too late to prevent the progression of the disease, but maybe you can stop it at a certain point and treat these people for longer. But I'm sure you will be talking to a joint replacement surgeon at some point who may well have different opinions about this. but I don't think they're going to be redundant for a very long time.
No. We are bringing an orthopedic surgeon who is going to talk about the knee replacement and mainly. Again, they do acknowledge that not every patient needs a knee replacement. There are an awful lot of work can be done well in advance before they reach the stage of needing a knee replacement. Yeah. They are there if their need arise, but they're not putting their hand out to invite people to go and get them done.
No. And I think, as a profession, we need to change the treatment paradigm here. We need to be allowed to treat these patients earlier in the disease process with products that may well delay the need for knee replacement, but we're hampered by increasing use of steroids and use of all the other products that we've spoken about, which are pure symptomatic treatments as opposed to treating the disease
and the core problem itself. What is your understanding about the various other knee replacements here? We got signature knee joint. That means they do a scan first, then it is bespoke made mainly for your particular joint that fits perfectly well.
I think this is a conversation for the surgeon.
Okay.
I'm not a surgeon, so I would not be happy about answering.
That's okay.
Specifics about knee replacement.
No, this is another product. The procedure surgeons are doing. They are finding very good results out of it. And the new one they are doing is a robotic surgery. That's another advancement in the knee replacement options. There are few more advancements in the world of knee replacement itself. Yeah. But all we are trying to do, there are loads of work needs to be done. People need to follow the pathways and get best care well before we reach the level where need the knee replacements. That includes lifestyle modification, understanding the disease itself, and treat the source of the problem rather than the symptoms of it, and find the really good treatment products available there to support us.
Absolutely.
And what will be your final message to any clinician watching this? Either a general practitioner or a physiotherapist or a dietitian watching this. What would you tell them? What are the steps they could do to help the patient in their early journey?
I think the most important thing is to get away from thinking that this is just a joint problem and it's just due to natural wear and tear and the inevitability of walking on two legs and living the life that we do. And it's more than that. So it's treating the patient as a whole. It's understanding that the issues that go along with osteoarthritis, nothing to do with joints, and the likelihood of patients getting arthritis. And it's identifying those patients much earlier in the disease process and treating, and hopefully we'll be in a position in the next few years where we will have far more options for treating the disease as opposed to the symptoms. The other thing I would say that, if patients are taking a bucket of NSAIDs a day and there's that temptation of starting them on opiates, try and avoid that if at all possible. Really, really do. Opiates have no place in the treatment of osteoarthritis because they do nothing for the disease. They just create people who are addicted to opiates.
Yeah, that is true. That is true. And this is a message we've been trumping up to every clients of us, and getting them to live longer, healthier, and leading a quality of life. These are all the major things we talk about. And, all this information, what we are providing today, will come in use to them. And so that they don't see that they need a knee replacement in few years down the road. So I'm not going to bother anyhow. I'm needing a knee replacement. I'm not going to try anything at all, so that I'll keep on popping pills. That's not the idea here. I'll emphasize this all the time. And I'll provide more information with various other therapies available. In physiotherapy itself, they could try ultrasound to ease the inflammation. And there are loads of pro-inflammatory products available on the market as well.
Yeah, we haven't talked to things about like glucosamines and chondroitin and all the other things that, I certainly don't think that they don't have a place. They certainly do have a place in treating these patients. Yes. And it's a combination therapy. And I'm sure there are other people who are better qualified
yes.
to talk about those. But it's certainly something that people, there are a lot of things available which are far better than taking
opiates and the NSAIDs.
Well, things that have side effects, and things that weren't really designed to be taken every day for days, months, years on end, because they do have problems.
And lots of my clients have said they've been taking turmeric, and that has been helping them. And loads of them go on glucosamine or chondroitin and cod liver oil, all those things. Loads of other therapies, remedies available. Again, what is right for you? You need to find out either with your general practitioner or your qualified clinician, so that you get the best understanding of it, rather than thinking, ibuprofen is the way forward.
I mean, you can do little trials on your own with these things if you suffer from osteoarthritis. If you start taking chondroitin or one of these other things, and just monitor how often are you buying ibuprofen. It may well find that you're only buying them once every couple of months instead of every other week or something. So you can monitor it yourself and see what's helping, because ultimately we still monitor this disease by progression of symptoms.
Absolutely, absolutely. I think that's a very good conversation. We had plenty of information here, and please, if you haven't watched the first and second episode, please go back and watch it. That give you plenty of information. In the final episode, we have given a summary of the other treatments available in the market for the treatment of arthritis, mainly the knee joint, and loads of them goes for the hip joint as well. But again, the message is talk to your general medical practitioner or highly qualified clinician. They'll give you the best information all about it.
Agreed.
Dr. Peter Shah, thank you very much for joining us today. It's fantastic to have you, and your energy was amazing.
I appreciate you taking the time.
Thank you. Take care.